Sitting at the base of the anterior neck is the thyroid gland. It operates as the master dial for human metabolism, synthesizing the hormones that regulate heart rate, body temperature, and energy expenditure. Structurally, this gland wraps directly around the trachea, bordered closely by the larynx, cervical lymph node chains, and the highly sensitive recurrent laryngeal nerves. This dense anatomical neighborhood plays a crucial role in how diseases of the thyroid present clinically. Microscopically, the thyroid contains two distinct cell lineages. Follicular cells form the vast majority, synthesizing standard thyroid hormones using iodine from the bloodstream. Interspersed C cells have an entirely different function, producing calcitonin to regulate blood calcium levels. When diagnosing thyroid cancer, the specific cell type that mutates dictates the behavior, aggression, and precise treatment required for the resulting tumor. Predicting how a thyroid malignancy will spread and knowing exactly how to destroy it requires mapping the pathology back to this microscopic origin. Over 90% of thyroid cancers are differentiated, originating in follicular cells. Papillary carcinoma is most prevalent, spreading via lymphatics to neck nodes. Follicular carcinoma accounts for 10%, bypassing lymphatics to spread through the bloodstream, seeding distant organs like lungs or bones. A related, more aggressive variant is Hürthle cell carcinoma. It derives from the same lineage, but is notoriously difficult to treat because its cells typically lose the ability to absorb iodine. Medullary thyroid carcinoma accounts for 3 to 4% of diagnoses. Originating in C cells, it secretes excess calcitonin. About 25% of cases are hereditary, driven by a RET proto-oncogene mutation within multiple endocrine neoplasia type 2. At the extreme end of the spectrum is anaplastic thyroid carcinoma. This rare, undifferentiated cancer has completely lost the structural markers of normal thyroid tissue. It grows and invades adjacent structures at a highly accelerated rate. Clinically, early-stage thyroid tumors rarely cause systemic issues or pain. The vast majority of cases are completely silent, discovered incidentally during routine physical exams or imaging studies ordered for entirely different reasons. Symptoms typically manifest when a growing tumor physically impinges on tightly packed anterior neck structures. Compressing the esophagus behind it causes dysphagia or difficulty swallowing. Direct pressure on the trachea causes dyspnea, complicating breathing. Infiltrating the recurrent laryngeal nerve causes progressive mechanical hoarseness. Because the disease develops quietly, the sudden appearance of these structural symptoms or the discovery of a painless lump requires immediate clinical investigation to confirm or rule out a malignancy. The diagnostic workup for a suspicious nodule begins with a dedicated thyroid ultrasound to map the physical architecture of the mass. This ultrasound interface isolates markers for malignancy. A high-risk nodule often presents with irregular, infiltrative borders and a physical shape that is taller than it is wide. Pathologists also look for microcalcifications, tiny calcium deposits scattered throughout the nodule that highly correlate with cancerous tissue. Ultrasound stratifies the physical risk, but it cannot definitively diagnose cancer. That requires extracting the cells themselves via a fine needle aspiration biopsy. Guided by the ultrasound, a clinician extracts cellular material from the nodule. Pathologists evaluate this sample using the Bethesda system, a standardized scale that assigns a precise risk of malignancy to the cytopathology. Parallel to the biopsy, a targeted blood panel provides the physiological context necessary to interpret the nodule's behavior. This flowchart tracks the lab workup. First, thyroid-stimulating hormone levels are checked. If TSH is exceptionally low, the nodule is hyperfunctioning, or hot. Hot nodules are actively producing excess hormone and are exceptionally rarely cancerous. If cytology suggests a medullary variant, the secondary pathway activates, measuring serum calcitonin and carcinoembryonic antigen levels to confirm the excessive C cell activity. By combining sonographic imaging, cellular biopsy, and functional lab data, clinicians accurately categorize the tumor and begin the staging process. This structural matrix illustrates the American Joint Committee on Cancer's TNM staging system, the universal framework for mapping the severity of a diagnosis. The algorithm calculates 3 clinical metrics: the size of the primary tumor, the extent of regional lymph node involvement, and the presence of distant metastatic spread. However, for differentiated thyroid cancers, the TNM system incorporates an unusual primary variable, the age of the patient at the time of diagnosis. For patients under the age of 55, the staging pathways are severely truncated. The entire matrix routes exclusively into either stage 1 or stage 2. This creates a unique staging paradox. In this younger demographic, even if the cancer has spread beyond the neck to distant organs like the lungs, the disease maxes out at stage 2. By contrast, patients aged 55 and older are evaluated on a traditional escalation curve, with aggressive structural spread mapping cleanly into stage 3 and stage 4 classifications. This age-dependent cutoff is driven by decades of clinical data. Differentiated thyroid cancers in younger patients demonstrate an extraordinarily indolent behavior and a highly favorable prognosis, regardless of initial spread. There is one absolute exception to these calculations, and it occurs when anaplastic thyroid carcinoma is identified. Because of its rapid, destructive clinical course, anaplastic cancer bypasses the TNM matrix entirely. It is automatically classified as stage 4 the moment it is diagnosed. This highly personalized staging algorithm ensures young patients avoid unnecessary aggressive overtreatment while instantly flagging critical variants that demand immediate intervention. For almost all structural thyroid cancers, the first and most critical line of defense is surgical resection. This 3D model compares the two primary approaches. On the right, a thyroid lobectomy removes only half of the gland, preserving some natural function for localized, low-risk cases. On the left, a total thyroidectomy cleanly removes the entire organ to clear expansive disease. If imaging or surgical findings indicate the cancer has breached the thyroid capsule and entered the lymphatics, surgeons will perform a targeted lymph node dissection to clear the affected cervical compartments. Once the bulk of the tumor is structurally removed, oncologists deploy radioactive iodine ablation to hunt down any microscopic cellular remnants left behind. This therapy exploits the baseline physiology of differentiated cells. Because normal follicular cells naturally extract iodine from the blood to build hormones, the mutated cancer cells do exactly the same thing, aggressively absorbing the radioactive payload and pulling it directly through their cell membranes. The isotope destroys the residual cancer tissue from the inside out, providing a highly targeted systemic sweep with virtually zero collateral damage to the rest of the body. This is precisely why tracking the microscopic origin matters. Radioactive iodine is completely ineffective against medullary or anaplastic cancers, simply because C cells and undifferentiated cells do not possess the biological mechanism to absorb iodine. To prevent recurrence, patients undergo thyroid hormone suppression therapy. By dosing synthetic levothyroxine slightly higher than baseline, the body suppresses its production of thyroid-stimulating hormone. Without the TSH signal, any lingering dormant cancer cells are starved of the biological trigger they need to grow. Radioactive ablation and hormone suppression succeed specifically because they engineer the tumor's own cellular physiology into a mechanism for its destruction. When patients present with advanced disease, distant metastases, or tumors that refuse to absorb iodine, the clinical algorithm requires a pharmacological pivot. Targeted oral therapies, like tyrosine kinase inhibitors, are deployed to sever the chemical pathways the tumor uses to build new blood vessels. For hereditary medullary cases, precision RET inhibitors directly neutralize the driving genetic mutation. For the highly aggressive anaplastic variants, oncologists rely on a rapid defense, combining targeted immunotherapy, external beam radiation, and chemotherapy to halt the tumor's advance. The ultimate success of these varying treatment pathways dictates the patient's long-term prognosis. This horizontal bar chart maps the stark prognostic divide that exists strictly based on the cancer's cellular subtype. For localized papillary and follicular cancers, the overall 5-year survival rate exceeds 98%. In younger demographics, these differentiated variants carry a long-term cure rate that approaches total eradication. Medullary carcinomas sit in the intermediate tier, presenting a steeper clinical hurdle, while the aggressive nature of anaplastic variants anchors the lower end of the prognostic scale. Despite the severity of these rare subtypes, continuous advancements in early genetic screening and precision oncology consistently push their survival curves upward. By accurately mapping a tumor's specific cellular origin, clinicians matched the disease to a highly refined surgical and chemical algorithm, rendering the vast majority of thyroid malignancies entirely curable.